our lecture today about respiratory problems that may the neonate complain from it during labor or after that. Respiratory tract disorders, in fact, so important subject because of many of neonates that admit to the intensive care unit complaining from respiratory tract disorders. And in presentation that we mention, consider important part of the respiratory distress. And all of these signs, symptoms, indicator that the neonate complain from certain problem regarding respiratory system. So, cyanosis, in fact, indicate serious problems that make you to interfere immediately. Of course, cyanosis means deoxygenated of blood in degrees that indicate a serious problem. Granting important sign of respiratory distress in neonate that indicate reduce the lung expansion and stiffness of the lung. Nasal flaring, also important indicator. Subcostal, intercostal retraction, beside tachypnea, and decreased breath sound with or without RAS. Pallor, of course, pallor not a specific sign of respiratory tract disorder, but of course, consider important. We should know why the newborn after complete delivery start to take breathing. So what are the factors that make such a neonate take respiration and depend on him or herself? So the factors that help a decline in pressure O2 and pH and a rise in pressure CO2 as a result of interruption of the placental circulation, consider important factor. Other, redistribution of the cardiac output because the newborn will be transferred from the intrauterine circulation to depend on him or herself. A decrease in the body temperature from the environment of the field, delivery room, or in theater. Besides that, various tactile and sensory input, especially the sounds of the personnel that work in the theater or delivery room. All of these help the newborn to take the first breath. When we talk about the neonatal problem regarding the respiratory system, we should start with hyaline membrane disease, so important subjects. Respiratory distress syndrome of the newborn, or we can say respiratory distress syndrome type 1 of the newborn. It's a respiratory disorder that primarily affects preterm. So, respiratory distress syndrome, a disease of prematurity. In fact, not found in term or post-term. Of course, these infants delivered before biochemical maturation of their lungs. What are the biochemical development of the lung? The most important perinatal event is the production of the surfactant, so important material that produced by type 2 alveolar cells. The major function of the surfactant is to decrease alveolar surface tension and increasing the lung compliance. So surfactant prevents alveolar collapse at the end of expiration and allow for opening of the alveoli at a low intrathoracic pressure. So the surfactant keep the alveoli open all the time, especially after exhalation. Of course, the component of the surfactant is lecithin and sphingomyelins, and the ratio between of these substances is so important. So the ratio of lecithin to sphingomyelin in the amniotic fluid is a reflection of the amount of the intrapulmonary surfactant and lung maturity. Percentage of lecithin to sphingomyelin 2:1 or greater usually indicate biochemical lung maturity. So if you have a premature labor and you want to be sure about the maturation of the lung of the newborn, you should examine the amniotic fluid for such issue. Surfactant increase by certain medications like steroid or prolonged membrane rupture, preeclampsia, placental insufficiency, thyroid hormone, and theophylline. All of these increase the surfactant maturation, while surfactant decrease by the following, and the most important condition, diabetes mellitus of the mother and acute asphyxia. Keep in mind, prolonged asphyxia, especially in placental insufficiency, increase the production of surfactant, while acute asphyxia, the opposite is true. Pathophysiology. The lungs are poorly compliant owing to the deficiency of surfactant, result in a classic complex of progressive atelectasis, intrapulmonary shunting, hypoxemia, and cyanosis. So the hyaline membrane that forms and lines the alveoli of the lung is composed of protein and sloughed epithelium. Of course, this is the result of oxygen exposure, alveolar capillary leakage, and the forces generated by the mechanical ventilation of these infants. All of these events may cause this membrane that line the small alveoli. What are the clinical features? Affected infant characteristic present with tachypnea, grunting, nasal phlegm, chest retraction, cyanosis in the first 3 hours of life. There is a decreased air entry on auscultation, apnea, and irregular respiration are, of course, important signs that indicate severe condition and that indicate immediate intervention. Respiratory failure, of course, can happen in severe cases. What are the natural causes of respiratory distress syndrome? Of course, it's a progressive in nature and worsening over the first 2 to 3 days of life. After the initial insult to the airway lining, the epithelium is repopulated with type 2 alveolar cells. After that, of course, after the 3 days of birth, there is an increased production and release of surfactant so that there are sufficient quantity in the airspace by the end of the 72 hours of life. This results in improvement in the lung compliance and resolution of the respiratory distress. Some large premature may be asymptomatic in the first 3-4 hours due to limited amount of surfactant, but after that, they start to be complained from the sign and symptom of respiratory distress. Most of the newborn improve after the 3rd day of the labor. This is an X-ray of the newborn with severe respiratory distress. As you see in this X-ray film, a lot of infiltration that called white gland or glass on a gland appearance. Beside, as you say, the arrows indicate the air bronchogram that indicate severe respiratory distress. This is another X-ray, but usually the newborn beside the sign symptom of the grand reticular formation and complicated by pneumothorax, Therapy and prognosis. Conventional therapy for the affected premature includes supportive care as well as the administration of oxygen. It's also necessary to increase the mean airway pressure by the use of continuous positive airway pressure, CPAP. Also, intermittent assisted ventilation or a high frequency oscillation outcome with conventional therapy is good. So, treatment start with supportive with oxygen. If not cure or improve the oxygen saturation, we can proceed for other exogenous surfactant replacement. Also, this amount artificial formulated surfactant or bovine surfactant has important intervention for those infants with severe surfactant deficiency. Of course, this material given through the laryngoscope insertion and delivered by tube to the lung. So, laryngoscopy with laryngeal tube that help for delivering such material inside the lung. Alveolar opening and improvement in the oxygenation and ventilation occur almost immediately after delivering of such material to the lung. Complication of RDS or respiratory distress syndrome of the newborn, type 1, pneumothorax, as we say in the previous film, patent ductus arteriosus. Actually, this type of duct status, functional in nature, traventricular hemorrhage, important complications, necrotizing enterocolitis, bronchopulmonary dysplasia, retinopathy of prematurity. Prevention. When amniotic fluid assessment reveal fetal lung immaturity and preterm labor cannot be prevented, administration of a corticosteroid to the mother 48 hours before delivery can induce or accelerate the production of fetal lung surfactant. So keep this possibility in your mind. Due to the complications that we mentioned, so later on, this newborn, after catching up growth, you should assess vision, hearing, cardiac, and nutritional status. So keep this complication that should need follow-up later on. So this is in summary regarding respiratory distress syndrome type 1. We have another clinical conditions that may be similar to the mild type of respiratory distress syndrome that called transient tachypnea of the newborn. Sometimes we call it respiratory distress syndrome type 2. So respiratory distress type 1 solely due to the deficiency of the surfactant, while type 2 transient tachypnea of newborn, of course, not due to the surfactant deficiency. So what are the idea behind this condition? The result, of course, from decreased lymphatic absorption of the fetal lung fluid. It most commonly occur in infants born near term by cesarean section without preceding labor, because the birth canal starts to squeeze the lung to get the extra fluid out. But here in cesarean section, this events not happen. Besides that, the catecholamine surge associated with labor and delivery, which is thought to enhance pulmonary lymphatic drainage, does not occur in this process. What are the clinical features? The tachypnea is quite or mild and usually not associated with retraction. The infant appears comfortable and rarely to be cyanotic. From the pathophysiology and the cause and the clinical feature, you can make a quick comparison between the syndrome type 1 and transient tachypnea of the. How we diagnose? Based on delivery and chest radiograph, which characterized by fluid in the major fissures, prominent vascular marking, increased interstitial marking, and hyperinflation. Sometimes auscultation may reveal RALs. Therapy of such problems, of course, supportive. The tachypnea resolved in a few days. Low dose of oxygen may be required. So the course run all the time as a mild dyspnea and mild retraction, and even no cyanosis or rarely to be cyanotic. So here, important to know the event of the labor, maturity of the newborn, and the clinical features and X-ray finding to differentiate which condition that I deal with it. Is it RDS type 1 of the newborn or transit tachycardia of newborn? Important to keep these differences between the two conditions. Here we talk about important issue that is persistent fetal circulation or persistent pulmonary hypertension. The same condition, usually a disease of the term infant. Keep in mind, premature that suffer from RDS and from newborn is a preterm, premature, while here we deal with the term infants. These infants experience acute or chronic in utero hypoxia. It is seen frequently in infants with meconium aspiration syndrome. So the cause almost inside the utero. What are the pathophysiology of such condition? The primary abnormality is a failure of the pulmonary vascular resistance to full with postnatal lung expansion and oxygenation. That should be at a normal state. The systemic vascular resistance rise as a result of the cessation of blood flow through the placenta, and the pulmonary vascular resistance fall with first breath. So in utero, we have, of course, the right side of the heart pressure more than the left. After birth, it should be reversed. But in persistent or the fetal circulation, this event not happen. And the right side continue to be the dominant in its pressure. So with persistent or fetal circulation, the pulmonary vascular resistance continue to be high and may in fact higher than the systemic resistance. This results in shunting of the deoxygenated blood, which is returned to the right side of the heart away from the lung. As you know, the blood in the right side of the heart should be pumped to the lung for oxygenation. While in this event, the right side of the blood of the right side will be pumped to the left side of the heart to be delivered to the systemic circulation. So the right to the left shunt can occur, of course, at both levels, arterial level, through the foramen of ovary, or through the ductus arteriosus. Because the lungs are bypassed, the blood is not oxygenated and hypoxemia, of course, the net result. So here we have a high right side pressure that help for delivered the blood with little oxygen to the systemic circulation. Clinical features. These infants are rapidly progressive cyanosis associated with mild to severe respiratory distress. There is a the valid response to the oxygen administration depending on the size of the shunt. Diagnosis. The diagnosis is suggested by a history of perinatal asphyxia and clinical cyanosis at birth, combined with negative cardiovascular examination and negative chest radiograph. So, when you examine the heart and the chest, and both of them were normal, and your patient complaining from severe respiratory distress cyanosis in term infant, you should raise the suspicion of the persistent fetal circulation. Helpful tool for assessing this abnormality by echo study. So echo can help to see the absence of cyanotic heart disease, increased pulmonary vascular resistance, the presence of the right to left shunt at the foramen of ovale or ductus arteriosus, or maybe both. So, normal cardiac examination, normal respiratory examination, while your patient still cyanotic and complaining from severe respiratory distress, you should suspect such abnormalities. Therapy. In fact, it's therapy so difficult in severe cases. Oxygen should be given, mechanical ventilation, hyperventilation, support of systemic blood pressure, administration of the sodium bicarb in metabolic or severe respiratory acidosis. Of course, pulmonary vasodilators may play a role. Prognosis. The overall mortality rate associated with this disease is high. Extracorporeal membrane oxygenation may improve the outcome. Of course, ECMO, extracorporeal membrane oxygen, ECMO, not available in our locality. So it's important clinical issue that follow birth of the term, that usually suffering from the chronic asphyxia in utero. Here we can talk about important subject that we call apnea of prematurity. Generally speaking, apnea is a cessation of the breathing for longer than 20 seconds. Apnea of the prematurity, we can say, or apnea of the newborn. Of course, reflect immaturity of the respiratory control mechanism in the brain stem. Clinical picture: bradycardia less than 80 beats per minute, often associated with apnea. Apnea of prematurity is characterized by periodic breathing and intermittent hypoxia, which further diminish respiratory drive. So apnea that considered significant associated with decrease in the heart rate, while usual apnea or usual periodic breathing not associated with bradycardia or change in the facial expression of the newborn. Diagnosis of the apnea. Of course, apnea of prematurity is made after exclusion other reason for apnea like respiratory problems, pneumonia, airway obstruction, hypoxia, or pneumothorax, CNS, intracranial hemorrhage, seizure, drugs, hypoxic injury, infections like sepsis, meningitis, metabolic important hypoglycemia, hypocalcemia, decrease or increase in sodium level, hypothermia, also important conditions, especially nowadays in cold weather. Cardiovascular, heart failure, hypotension, gastrointestinal necrotizing enterocolitis. So, don't say apnea of prematurity unless you exclude these important newborn conditions. Therapy of the apnea. Therapy of apnea of prematurity include one of the following: tactile stimuli, so important, maintain body temperature, supplemental oxygen in severe cases, or prolonged apnea, administration of the respiratory stimulant, theophylline or caffeine, use a continuous airway pressure, or intermittent assisted ventilation in severe cases, and of course, treat the underlying cause. Treat the underlying cause. Apnea of prematurity does not alter prognosis unless it is so severe. Unless it is so severe. So today we talk about apnea of premature that occur in the premature. We talk about the respiratory distress syndrome that occur in the premature. We talk about the transient tachypnea of the newborn that occur in the premature. And we talk about the persistent fetal circulation that happen in term infant, not in a premature. Keep in mind. We proceed for another important condition is a unilateral or bilateral obstruction of the posterior nasal airway. This obstruction by membrane or bony septum. This is a life-threatening anomaly resulting from the failure of the bucconasal mucosa to rupture. Of course, consider life-threatening condition if it occurs bilaterally. Clinical features, because most of newborn are obligate nose breathers, bilateral atresia usually present in the delivery room as airway obstruction, apnea and cyanosis, distress neonate, then cry which relieve the cyanosis. Unilateral atresia may be asymptomatic. Here, very important attention to this newborn, because this newborn, when it starts to cry, the cyanosis and clinical features of respiratory distress are relieved, because the newborn take aeration through the mouth, and then during quietness of the newborn, the cyanosis and respiratory distress recur again. So this sign symptom that follow cry and quietness of the newborn raise the suspicion of choanal atresia. Keep in mind. So the observation of such a newborn so important. The child or the newborn start to cry will be changed to be pinkish, while when the newborn pass the quiet state, the signal start to return again. So important observable signs of such problem. Diagnosis is confirmed either by inability to pass oropharynx or by radiography using a suction catheter through the nostril into the radio-opaque dye, show the area of nasal obstruction. So important. Failure of passing of the catheter in the neonatal room, in the neonatal delivery room. So important sign. Sometimes may be discovered accidentally if the lesion unilateral. What are therapy? Emergency management consists of establishing airway either with oral airway or by endotracheal intubation. Of course, definite therapy is surgical reconstruction performing in the neonatal period in case of bilateral lesion. Unilateral may be corrected later on. So important anomalies in a healthy appearing mature or premature baby, mature or premature baby. Diaphragmatic hernia. Diaphragmatic hernia is a displacement of the abdominal content into the thoracic cavity through the defect the diaphragm. As you know, the diaphragm is an important respiratory muscle that separates from the lung from the intra-abdominal organs. Here we have a defect in this diaphragm, and so herniation of the abdominal organ inside the chest. In fact, we have two types of the hernia. Hernia through the foramen of Bagdolak are by the far the most commonly seen in diaphragmatic hernia. The defect, which almost always on the left, occur in the posterior lateral portion of the diaphragm. The result from failure of the pleuroperitoneal canal to close, which normally occur between 6 to 8 weeks of gestations. So the defect from the start and failure of fusion of the diaphragm are the posterior lateral portion. Another herniation through the foramen of Morgagni are somewhat rare, and the hernia usually on the right. Frequently, the hernia contains only omentum, and the affected newborn is asymptomatic. Consider, of course, later on by X-ray that show elevated the right side dome of the diaphragm. Pathophysiology. Ipsilateral pulmonary hypoplasia results from the compression of the affected lung by displaced gastrointestinal organs. So, first, we have compression of the lung on the same side. Other lung may be affected by shifting of the mediastinum and result in compression of the another lung. So, in severe cases, we have a hypoplasia of the both lungs. And most of cases, in fact, we have a hypoplasia of the one side that result in the same side of hernia. Of course, the newborn with both lung hypoplasia, severe respiratory distress immediately after birth. Diagnosis: of course, the diagnosis is confirmed by chest radiograph demonstrating air-filled bowel in the hemithorax. So easily to be demonstrated like this X-ray. Here we have a lot of air following the bowel that occupying the whole left lung and displacement of the lung to the other side, Even the cardiac shadow displaced to other side. So X-ray considered important tool for diagnosing such congenital abnormalities. Therapy: immediate intubation, vigorous oxygenation and mechanical ventilation, decompression of the intestinal tract with nasogastric tube, important. Early intervention to reduce the intestinal tract, important to correct and deal with the metabolic abnormalities. Of course, later on, definite treatment by surgical removal of the abdominal content from the thorax will repair the defect. Important note regarding this abnormality: mask and ambu bag ventilation should be avoided because a lot of air will pass in the stomach and the intestine, and this increases more pressure on the lung. Pulmonary hypertension frequently complicates the preoperative and postoperative course, so keep this possibility in your mind. Extracorporeal membrane oxygenation may be helpful in selected infants. Important conditions. Why it's important? Because it's preventable by immediate intervention and repair. So don't postpone the operation to avoid a lot of disturbance in metabolism that make the newborn may complain from more problems. Prognosis. Survival rate depends on the degree of the lung hypoplasia. Of course, in both lung hypoplasia, we have a lot of complication later on. The presence of other anomalies, early symptoms, herniation to the contralateral lung, or need for ECMO. With conventional therapy, survival rate are approximately 77%. However, the use of extracorporeal membrane oxygenation may help and increase the survival rate. Of course, this condition occurs in both mature and premature baby. Mature or premature baby. Here we talk about important meconium aspiration syndrome. It's an important condition. Why it's an important condition? Because it is preventable. Of course, it's a disease of maturity or post-maturity. Meconium aspiration syndrome is a multi-organ, multi-disorder with perinatal asphyxia as the underlying cause. It's most commonly occur in post-term infant and infant who are small for gestational age. Small for gestational age, of course, not mean premature, as we discussed in the previous lectures. Of course, this abnormality is due to the intrauterine growth retardation. Of course, placental insufficiency is an important condition for fetal hypoxia. So it is a disease of mature or post-mature newborn. Pathophysiology behind the meconium aspiration syndrome. If one of you asks about the meconium coming from where? The meconium of the newborn intestine comes from where? Of course, come from the continuous shedding and collecting of the intestinal cell during the gestation. So it is collected inside the intestine and should be kept then with tight anal sphincter. Pathophysiology. The fetal hypoxia triggers via vagal reflex. So the passage of thick meconium to the amniotic fluid. In fact, the amniotic fluid should be sterile all the time. Here, passage of the meconium inside the amniotic fluid change the media from the sterile to the infected or contaminated fluid with a lot of meconium. As we said, hypoxia resulting in relaxation of the anal sphincter. And this is an important point. Why this condition not happen in the premature? Because premature anal reflex will be respond weakly to the hypoxia and kept itself tight a long time in spite of hypoxia. So the contaminated amniotic fluid is swallowed into the oropharynx and aspirated at birth within the initiation of breathing. So your action should be interfere in this point before the neonate taking its first breathing. With severe fetal hypoxia and asphyxia, the meconium may be aspirated prenatally because of the fetal gasping. Besides affecting the lung, other organs may be affected: brain, heart, GIT, and even kidneys. Diagnosis. The diagnosis is established by presence of meconium in the trachea or amniotic fluid combined with symptom of respiratory distress. Of course, the chest diaphragm that reveal a pattern diffuse infiltration with hyperinflation. Keep in mind, presence of the meconium at birth always indicate respiratory distress that should be diagnosed and should be treated immediately. Our job to prevent of reaching of such meconium to the lung of the newborn. Therapy. Because most episodes of aspiration occur with initiation of the respiration So the most effective therapy is prevention. This consists of removal of the meconium before the initiation of ventilation. The meconium is removed from the infant airway as follows. The oropharynx is suctioned before both delivery of the thorax and initiation of breathing. And again, when the infant is on the warmer bed. So just when the head comes out, you should suctioning of the mouth and don't induce breathing unless you clean the area. The suctioning, of course, continued even after complete delivery under the warmer bed. The vocal cords are visualized using a laryngoscope and a large endotracheal tube or DeLee suction catheter is inserted. DeLee catheter, special catheter that help in suctioning a lot of meconium in the oropharynx. Direct wall unit suction is applied to the tube or catheter as it's removed. This procedure is repeated if significant meconium is removed. So the action will be continue till remove all the meconium inside. Artificial ventilation may be needed in severe cases. If aspiration has occurred and the infant is in distress, therapy consists of administration of oxygen and mechanical ventilation. Persistent pulmonary hypertension also may be exist and should be vigorously treated. So, as we say, it is a disease of mature that can be easily prevented, but if not prevented, it results in severe respiratory distress, especially in state of thick meconium, because we have a thin and thick meconium according to the severity of the asphyxia inside the utero. Up to this point, we can stop and we continue in the next lecture. Any question?